We're live. Howdy, everybody. Aaron Boster here, and thank you for learning about MS with me. It's about 10:30 at night on a Thursday. That's 10:30 Eastern Standard Time. My family all just went to bed. I am hyped up from today, and I wanted to jump online because I missed you guys. Say hello, howdy, hi. Maybe take some of your questions and talk a little bit about multiple sclerosis. You guys might be noticing I'm wearing an awesome hat. I had a wonderful family that gave me this hat as a gift, and I'm loving it. Hello, AJ's HR. It's great to see you. 115, how are you doing? I've got Kaya on the line and Debbie Bell. Hello, hello. Stephen Craver's coming on. Hey, Stephen, how are you doing? Game Shakers here. Michelle Charles says, can you let me know what to expect about pregnancy with us? I'm 11 weeks. So we've already got the first question. That's a great question. I'm going to pose it again. And a couple housekeeping rules as we jump online, guys. When you jump online, please tell me where you're logging in from. Hello, Laura out in Boston. I hope you're doing well. And so tell me where you're logging in from, because I love this global online community. It's great to see where everyone's calling in from. Also, I want to answer your questions. It helps me if there's moderators on the line. And I think I saw AJ's HR has jumped online, so I'm going to ask AJ's HR to please help. If the moderator would identify a question, copy it and paste it. Say question and then list the question by ever whom asked it. That makes it easier for me to find. So AJ's HR, if you're okay with that, give me a thumbs up and let me know that's an okay idea. Also, I've got my grog here, and so feel free to jump in and share with me where you think what you think I'm drinking in this grog. In other words, what is Dr. B's grog tonight? So take a crack at what you think this is. AJ's HR is ready and willing. Thank you very much. As you guys have live questions, go ahead and ask them in the comments. AJ's HR is going to identify the question, copy it and paste it for me. It's easier for me to find it that way. Any question that I don't get to, I'll answer on a later live stream, or I'll answer it in an upcoming video. While we are getting ready and AJ's HR is getting geared up, let me answer the first question about pregnancy. Now, I have a video that I've done on pregnancy, and it's a very comprehensive discussion of pregnancy. And so I'm going to direct you to that video. I don't think I'm savvy enough while I'm online, but I'm going to try to do it anyways, to find that video and then attach it to a link. So wish me luck. I'm trying to do two things at once. And I'm going to link that video about pregnancy so you guys can find it. Let me see if this works. Oh, and it did work. All right, good things are happening. Let me copy this for you. And I'm surprised I was able to pull this off. So here's pregnancy in MS. So there you go. Check out that video if you haven't seen it already. It's a very comprehensive discussion about pregnancy. Now, just to share a little bit on the live stream about pregnancy, MS doesn't interfere with the ability to become pregnant. So MS does not affect fertility. I sometimes feel like my patients are even more fertile than the average Joe. But MS doesn't impact fertility. MS also does not increase the risk of spontaneous abortion. It does not increase the risk of fetal malformations or birth defects. And so in some ways, MS doesn't affect pregnancy. Now, I don't feel that someone with MS necessarily needs to be in a high-risk OB clinic. Oftentimes, OB-GYNs will put MS patients in high-risk clinics, and I never correct them because I like the attention that you get. But it's not really a high-risk pregnancy state. The likelihood of having an MS attack is about the same when you're not pregnant as it is during the first trimester. However, when you enter into trimester 2 and 3, the risk of attack actually goes much lower. Now, after delivery of the baby and you deliver the placenta, the risk goes up. And I'd like to spend a few minutes and explain to you why. When you become pregnant, half of the genetic material of the fetus is yours and half is your partner's. And that's really foreign DNA. Now, normally your immune system doesn't like foreign DNA. And when it sees foreign DNA, it would try to kill it. And that's obviously not the goal of the pregnancy. The placenta pumps out estriol, which is an estrogen, at very, very high levels. And these high levels of estriol, of estrogen, protect the fetus from the immune response. So it creates an immune protected state. Now, here's the cool thing. It doesn't just protect the fetus, it affects the whole body, so it protects the brain also. So while you're pregnant and while you have a placenta that's pumping out estriol, you'll find that the risk of MS activity is much less. After delivery, you deliver the baby, and then you deliver the placenta, and the estriol levels go back down to normal. And in what I call the fourth trimester, which is the trimester after delivery, the risk of attack actually goes up. If you look over a year, it's a wash. Now, to address this concern about an attack after pregnancy, we generally, as a party line, don't do special interventions with the first pregnancy because we don't know that the person's going to be at high risk, and some of those interventions carry risk along with them. If, however, we know that a woman is at risk of having another severe attack, like maybe with her last pregnancy, she had a severe attack, we might give her IVIG or even steroids immediately after delivery. And that's obviously something that an individual woman has to work out with an individual doctor for that individual situation. Now, there's a lot more that I could say about pregnancy, but I'm going to encourage you to jump on that link that I just listed. And there's a very comprehensive discussion talking about pregnancy. I even get into some of the therapies that we're starting to use during pregnancy. When I was in training, we stopped all therapies during pregnancy. Now we realize that allowing someone to have an attack is not the best thing to do. And in some cases, it's better to keep a woman on a therapy, a disease-modifying therapy, than it is to take her off. Now, again, I want to point out this awesome hat. I'll get a close-up here so you guys can see. That says FUMS. And if we spin it around, that says Kick MS. And I am absolutely digging this hat. I am so excited. It was a gift that I got earlier this week. I'm loving it. Once again, feel free. Mama Bear Norton thinks that there's water in my grog cup, and tonight it is not water. I'll wipe the foam off. So, aha. Michelle Charles says beer. Now, Michelle, you may be onto something, and this is in fact beer. And for extra credit, I'll let you guys take a crack at what kind of beer I might be drinking. Now, Kristen Lynn writes in a great question and says, Dr. B, what are you thinking about Mavenclad compared to Lemtrada? So, Kristen Lynn, that's a great question. Let's talk a little bit about Mavenclad and Lemtrada. Mavenclad and Lemtrada are both MS disease-modifying therapies. They're both intended to decrease attacks, to decrease accumulation of disability, to prevent new spots on the MRI, like all MS disease-modifying therapies. Now, Lemtrada is an intravenous medicine given through the vein. It's a monoclonal antibody that identifies adult T cells and murders them, and then forces the young guns to grow back more well-behaved, which is a form of immune reconstitution or a reboot of the immune response. Lemtrada is given in a weird manner. It's given for 5 consecutive days, wait a year, 3 consecutive days, and then you don't retreat unless you have further disease activity, meaning another relapse, God forbid, or new spots on an MRI in a future scan, God forbid. Now, if you have those things happen, then we can give another course of Lemtrada. And when we look out 8 years, about half of people never get retreated after the first 2 courses, and about 30% get a 3rd course, just to give you guys an idea. Now, Lemtrada, in my opinion, is one of the more effective, it's probably one of the most effective MS medicines, and it boasts really impressive numbers as it relates to reducing relapses, decreasing accumulation of disability, and in fact, increasing the likelihood of confirmed disability improvement. It does some really cool things on the MRI. Now, keep that in your head, and I'm going to talk about cladribine. Cladribine is also an immune reconstitution therapy. It's mitoduction therapy. Cladribine is a pill that you take, and you take 1 or 2 pills each day for 5 days in a row. So I sort of sometimes joke that cladribine is like a reverse birth control pill. Remember the birth control pills that you would take all month except for those 5 days or 7 days. So this is the opposite. You're only taking 5 days of medicine the first month, 5 days of medicine the second month. Then you do nothing for the first year. And then you do 5 days the first month, 5 days the second month. And then you're done being treated with cladribine. Now, cladribine, like Lemtrada, mechanistically, it kills adult B and T cells. And the adult B and T cells come back much faster, which is why the dosing is done differently. And cladribine is not intended to be redosed. Now, there was a clinical trial for cladribine called the Clarity trial. This is a trial I was a sub-investigator for many, many years ago. And the trial was concluded, and the company that makes cladribine submitted to the FDA back in 2008, and they were told no. They were told refusal to file. There were major concerns about cancer risk at the time, and so the FDA did not move forward. Now, they closed the cladribine program, and so there was no long-term cohort that's been studied for an extended period of time with cladribine, particularly not in the United States. And yet, 10 years later, they resubmitted and they were given approval this year. So cladribine is in fact one of the newest medicines to join the MS market. I personally view cladribine as a moderate level efficacy. To me, it's efficacy similar to that of Gilenya. It has a 58% reduction in relapses compared to placebo, and it's got about a 30% reduction in disability compared to placebo. And compared to placebo, it cleans up the MRI rather handsomely. Now, we don't have an active comparator with cladribine because at the time the trials were done, we didn't do active comparators. Lemtrada was compared to Rebif. Cladribine was compared to placebo. And so we don't know how cladribine would fare against another drug. We also, because they stopped the trials, do not have long-term follow-up. And this brings me to my first concern. In the American label, it states that when you give cladribine after the first 2 years, you may not give it again for another 2 years. So if you were give it in year 1 and year 2, you're not allowed to give more cladribine in year 3 and year 4 because of the concern for cumulative cancer risk. And this is a problem for me because cladribine is approved in the American FDA second line, which means you're going to go on to cladribine largely when another drug has failed you, when you've had breakthrough disease. So you already are entering into cladribine with an active disease state. If cladribine works, then that's great. But if it doesn't work, if you have breakthrough disease, I think that there's a bit of a quandary about what to do because I can't give you more cladribine. With Lemtrada, I can give you more Lemtrada. With cladribine, I'm not allowed. And the reason I'm not allowed is because cumulative cancer risk. So what about giving another immunosuppressant? Lemtrada is another immunosuppressant. Ocrevus is an immunosuppressant. Many of these drugs function in a manner that's immunosuppressive. Is there a cumulative cancer risk if I give cladribine and then Lemtrada, or cladribine then Ocrevus? And the answer is we don't know. We don't know because there's no data. So my opinion is that cladribine is an interesting medicine. I think cladribine is fascinating in its mechanism and the way that it's given. I think that the efficacy is medium range. My opinion is that the efficacy is on par with Gilenya. I do not think cladribine is as efficacious as the monoclonal antibodies, Tysabri, Lemtrada, and Ocrevus, but I think that cladribine is probably more effective than the shots. I also am very bothered by the fact that I don't have long-term follow-up with cladribine and I'm not allowed to redose it. So those are some initial comments. I hope that this comparison of cladribine and Lemtrada is helpful. And as we learn more about cladribine, as I learn about cladribine, I'll most certainly share that with you guys. So AJ's HR is a wonderful moderator and they're helping me out. Thank you very much. AJ's HR has copied a question written by Jennifer. So Jennifer writes in, had 2 Ocrevus infusions last in July, had a relapse in April. Do relapses occur in Ocrevus patients? And the answer is yes. Relapses can occur on any medicine. So there is no MS medicine that guarantees 0 relapses. The goal when taking these medicines is not to have a relapse. That's the goal, but we don't always achieve the goal. And so then we have to ask ourselves the question, if you're taking a birth control pill and you get pregnant, it didn't work. So if you're taking a medicine intended to prevent relapses and you have a relapse, there's a sense that it didn't work. No medicine is perfect. And so we have to come up with the way that we want to approach this problem. One way is to say, one attack, we're done. And in some cases, that's what we do. We say one attack and we escalate to a different therapy. There's another approach, which is to say, one attack and I put you on warning. And if anything else bad happens, then I upgrade. And that's another approach. And clearly different practitioners and different patients together as a team will adopt whichever approach makes sense for that individual. Having an attack on Ocrevus isn't proof that it doesn't work, but it most certainly is concerning. And if you opt to continue on Ocrevus, then I most certainly would not allow any further disease activity, or I would escalate to something else. I hope that helped answer your question. That was a really good one. Thank you, Jennifer. The next question comes from Lois Poe, who asks, does MS cause stuttering? And the answer is no. Stuttering is not caused by MS. Now, stuttering is super frustrating and super annoying. One of my very close friends, a guy that I love, a gentleman that I went to college with named Jafar, is an amazing, amazing friend. He also speaks Arabic, French, English, and Spanish. He's very, very multilingual, and he stutters in all 4 languages. And my heart goes out when he would be speaking and he would start to stutter. And it was so frustrating to watch. And I can only imagine how he feels. I can only imagine how someone with stuttering feels. But MS does not cause stuttering. Sometimes nature's a little too generous, and you can have MS and you can have a stuttering problem. The good news is there's ways of treating stuttering. So working with a speech pathologist is the first approach, and they are really, really good at helping people overcome stuttering. So if the person that wrote the question or someone else listening in grapples with stuttering, I most certainly would work with a speech pathologist to try to beat that. So Homesick Nomad Jervy writes in, have an upcoming neuropsych test. Is it important to bring someone with me? Tips for prepping. Great question. Now, first of all, guys, Homesick Nomad is an artist. He's a musician and he's an artist. And he recently hooked me up with some of his music, and I love it. And so I am looking forward to showcasing some of his music on this channel. I haven't done it yet. It's a project probably for this weekend or next week, but I really want to showcase some of his cool music. And so you guys can look forward to seeing some of his tracks on my channel. So you guys can check that out. He's got a website, and you guys can go listen to the tracks and download them, and you can help him out. So I'm going to be showcasing that in the near future. But to answer his question, he says, I have neuropsych coming up. So how do you prep for neuropsych? Number 1, get a lot of sleep. So you want to get a really good night's sleep. Number 2, you want to not enter into the neuropsych testing all stressed out. So I wouldn't try to sell your house and then go do neuropsych testing, or close a big business meeting and then go do neuropsych testing. I want you to be calm, cool, and collected. I would make sure that you've eaten well, and I would steady myself to have a long series of paper and pencil tests with the neuropsychologist. Now, I don't know that you need to bring someone. If you're meeting the neuropsychologist for the first time, it maybe is helpful to bring a loved one who can help buttress your history and share details that you might forget. But if you're actually going for the paper pencil test, the neuropsych testing, which is done with a neuropsychologist, you probably don't need to have a loved one with you during the test itself. I hope that those are helpful. Now, a couple other things to prep. If you've had prior neuropsych, you must bring that with you, because it's super helpful, because it teaches the neuropsychologist about what's been going on in the past and helps them evaluate the current steady day. Plus, if they have an old one and they have new neuropsych, they can really see the trajectory of the cognition. And so that can be super helpful. Any other documentation you have, either from working with speech pathology for cognition, or if you've worked with a psychiatrist and neurologist, bringing those clinic notes might also be of value. So I hope that helps, and I wish you the very best of luck with the neuropsych testing. Neuropsych testing is very useful. I have a couple of videos on my channel about cognition. And in one of them, I talk about neuropsych testing and how I recommend using it. It's a very, very powerful tool. It's good stuff. We get neuropsych on patients most commonly when there's a problem in the workplace or in the school place. And so people are maybe getting poor performance because they're cognitively impaired. And we want to be able to document that it's not them, it's their disease. We also find that neuropsych is very helpful when we're really starting to dive into why there's cognitive problems. Because on a neuropsych test, you can learn, hey, compared to someone your age and your educational level, you do way better in these 5 things. You're on par with these 10 things. And these 3 things you're really bad at compared to other people your age and your educational level. So if we can identify what the bad things are, what the good things are, we can leverage the good to help the bad. I'll give you an example. Sometimes in neuropsych testing, we'll find that your visual memory stinks. Your ability to read something or see something and remember it is really bad, but your auditory memory is on point. So if you hear it, you can remember it. Now, if you learn that, then the action is when someone tells you something, or if they're going to hand you something to remember, you have to have them say it so you can hear it also. Because the neuropsych has taught us just reading it alone is not going to help inscribe it into your memory. You're going to have to read it and hear it. And so that's just an example of where a neuropsych can be very, very helpful. And I'm going to rock this hat a little bit tonight because I'm loving it. All right, let's look for another question. All right, so Tim McCready writes, my neuro told me if I don't increase my white blood cells, he's going to take me off Gilenya. Is there a natural way to increase? Suggested next treatment options. Okay, so I'm going to explain why, in my opinion, that doesn't make any sense. I am not giving you medical advice, and you have to talk to your provider because your provider and you have a special therapeutic relationship. And me talking to you over the interwebs at 11 o'clock at night or 10 o'clock at night doesn't suffice to fill that in. But Gilenya is a very unique medicine. Gilenya causes about 80% of your white blood cells to go out of your bloodstream into your lymph nodes, and it traps them in the lymph nodes. So we move 80% of your white blood cells out of the bloodstream into your lymph nodes. If you take a needle and stick it in your vein and draw back red blood and look at it under the microscope, you're going to say, oh, there's not a lot of cells there. Your white blood cell count is low. Well, it's low because the cells aren't in the bloodstream. They're in the lymph nodes, but you still have them. Those cells are trapped in the lymph nodes. Now, they can still function. They're just trapped in the lymph nodes. And if you stop Gilenya, it would release them all back out. So here's the deal. Most doctors don't know that. And in fact, many neurologists, unfortunately, don't know that. Every single other medicine that exists, except Gilenya and Mayzent, don't do that. That's not the way they work. Every other medicine, if the white count's low, it means that you're immunosuppressed and at risk of all kinds of crazy infections. With Gilenya and with Mayzent, if the white count's low, it means you're taking your drug. And there's no possible way of looking at the white count and correlating that to risk of infection. I actually authored a paper that was published a couple months ago on this exact topic. And so if you go into PubMed and type in my name, Aaron Boster, my most recent publication, or one of my most recent publications, is this exact paper where I talk about the fact that you cannot use the level of the white blood cell count to monitor safety from infection when you're on Gilenya or Mayzent. You cannot do it. Instead, it's a way of knowing that the person's taking the drug. If I have a patient on Gilenya and their white count is normal, I know they're not actually physically taking the medicine. And we have to talk about that. And so my point here is this is a very common mistake that I think doctors make. They see the white counts low, they get all nervous about it, and they don't realize that the way the medicine works disallows them from assessing it. So you might ask me, well, gosh, Aaron, how am I supposed to know if I'm at risk of opportunistic infections? Well, the way that I do it is if you, I'm just going to rock this hat a little bit. If you are having lots of little infections, you're having urinary tract infections, upper respiratory tract infections, fungal infections, skin infections, then I'm going to take you off that drug because I'm getting a sense that we're having a risk of opportunistic infections. But if you're stable on Gilenya and your white count's really low, I'm not bothered by that. So I hope that helps to answer your question. Now, the other part of the question was, what would be the best next drug? And that's an impossible question to answer unless I have a lot more information. But I'm going to share my style. My style when we leave a medicine is to upgrade to something that I think is more effective. So if you're driving a Honda and we're going to get rid of the Honda, I'm not going to get a Toyota. I'm using that as a silly example of analogous level cars. I'm going to go from a Honda to a BMW 5 Series. I'm going to really knock it out of the park. And so if we leave Gilenya for whatever reason, I'm looking for an upgrade. I'm typically looking to use one of the drugs that, in my opinion, is more effective. I've got a video on my channel where I give you my opinion about the efficacy of drugs. And so you can definitely check that out. And the whole goal here is to kick MS. I'm loving it. All right, that was a great question. Thank you for asking it. Guys, it is 11 o'clock at night, Eastern Standard Time, and there is 122 of you online. Mwah, mwah. Thank you very much. That's awesome. You know, the reality is I had a rough day today. I had a difficult day with a lot of really frustrating meetings, and I am grateful for this opportunity to chill out with you guys. When I was finishing up my workday, I was in a business meeting for research, and my phone died, like stopped working. And I'm on call, taking phone calls periodically from the hospital. And so I freaked out. And I spent the entire night up until maybe about 9 p.m. At the store getting a new phone. And so this is my brand new phone. It's like brand spanking new. Like I literally just got it. And it was so frustrating trying to get my phone to work. So now I have a working phone. I'm feeling much better. I'm through my busy, stressful day, and I get a chance to chill out. And it's really special to me that I can do that with 122 of you from around the globe. So here's to you. God bless. All right. So let's see what the next question is. So Tricia Coleman writes in, Gilenya can cause skin cancer and liver problems. Will sun exposure and alcohol, in addition to Gilenya, double your risk? So Tricia, thanks for writing in. There have been 9 cases of melanoma, and there's been 190,000 people on Gilenya. So whereas I think it's very important to screen your skin once a year with a derm exam, either by a dermatologist or by your general practitioner, I'm not convinced that Gilenya increases the risk for skin cancer. Liver problems are not common with Gilenya. Gilenya is metabolized by the liver, and you have to check liver enzymes every 3 to 6 months. And when liver enzymes go up in Gilenya, they go way up. I mean, like 5 times the upper limit of normal. And they typically do it within the first year. Not always, but typically. So if you're on Gilenya and you're checking your labs, and we notice that your liver enzymes go up, we can stop the medicine, watch them go back down. Now, the first question is, if you have sun exposure, would it increase your risk? And the answer is yes. Now, I just finished telling you that I'm not convinced Gilenya causes increased risk of skin cancer, but sun exposure certainly does. And so we have to kind of weigh all of this, right? I'm not scared of skin cancer if you're on Gilenya, but I want you checked out by your dermatologist once a year. And I also think that being cautious about the sun is important because skin cancer caught early can be cured. You can cut it out, but caught late will literally lead to death in some cases. And so sun exposure is one of the major risks of skin cancer. Do I think people on Gilenya need to avoid the sun? No, I don't. I think Gilenya is a drug mostly for young people. I think Mavenclad is a drug mostly for young people. These are S1P1 receptor modulators. And I don't want young people stuck inside. I want you out living life and doing stuff. But sunscreen is your friend, and putting a hat on is your friend, and covering up is your friend so you don't bake your skin and increase the risk of skin cancer. Now, alcohol was the other question. So if I'm on Gilenya and if I drink alcohol, what might happen? Again, a couple things. I have a video on my channel where I talk about alcohol and MS. And so if you haven't checked that out, you might consider checking out my video on alcohol and MS. You can find that on this channel. And I think we need to drink alcohol in moderation. So I think that anyone that's going out and drinking to excess puts themselves at risk. And I think that we have to keep checking liver enzymes while you're on Gilenya. So do I think it's awful and horrible to have a beer while you're on Gilenya? No, I don't. Do I think it's a bad idea to have 7 in one night? Yeah, I might. And that's not a statement specifically about Gilenya. That's more of a statement about consuming in moderation. So what's the next question here? Well, I'm looking for another. Here's another question. So LAW asks, is the progression better for someone diagnosed at a later age? So this is very interesting. If you look at someone who's diagnosed before the age of 18, so pediatric onset MS, folks with pediatric onset MS tend to accrue disability slower. But since they started at a younger age, they oftentimes end up more disabled at a younger age because they started at a much, much younger point in time. People who are diagnosed after the age of 40 tend to have a faster progression of disease, but they're already 40. And so it's very interesting. Prognostically, being diagnosed later is a bad prognostic factor for progression because you can get there quicker. But being diagnosed really early gives you more time to accrue disability. So it's a very interesting quandary, and I hope that helped address your question. Jennifer writes in, what exactly is a moderate lesion load? I have lesions on the brainstem, spine, and optic nerve. So the lesion load is a radiology comment or a neurologist comment on the gestalt or number of spots on your MRI. And I don't think that there's a set number, like 4 is low and 10 is medium. I don't think you can say something like that. It's really a gestalt. When I look at an MRI, one of the things that I report on is mild, moderate, or severe burden of disease. Burden of disease being the lesion load. And I'm basing that on having looked at thousands of, probably tens of thousands of scans over the last 13 plus years. And so I've sort of developed an opinion on that's not so much, that's a lot. But without looking at your scan, I really can't comment. So here's another question. This one is from Cheryl, where to go? Cheryl Palmer asks, is there lymph involvement in MS? So I'm not exactly sure what you mean by lymph involvement in MS. In some ways, the answer is no, but in some ways, the answer is yes. And let me explain what I mean. The MS involves the immune system and its impact on the nervous system. And so the lymphatics aren't necessarily involved, but the immune cells circulate through the bloodstream in the lymph nodes. And so they do circulate through the lymphatics. There isn't clear evidence that lymph problems are linked to MS. And so if I had to put my penny on the table, I would say no. Now, before I answer another question, I just want to reflect that there's still 120 people online, and that's freaking awesome. Thank you, guys. If you like what I'm doing here, please give it a thumbs up. You may have to close the window and then click the thumbs up button and jump back into the window, but show me a little love and give me a thumbs up if you like what we're doing here. It's 11 o'clock at night. I should probably be sleeping, but I'm too wound up from today, and I wanted to kick back and chat with you guys because I missed you. I also want to reflect on something, something kind of personal that's neat for me, and I wanted to share with you guys. Today, this week was a busy clinic week, and there were 2 patients that came to see me from a distance. There's a patient that came to see me from Florida, and there's a patient that came to see me from India. And I want to share with you how that makes me feel. Now, I am very passionate about beating up MS, and I'm very passionate about making people with MS the most awesome version of them. And I don't really care where they live. I just want to help them. But the fact that people got on a plane and traveled to see me means a lot to me. And so I just wanted to share that with you guys. It's really special that I can help a family. And if that family is in my hometown of Columbus, Ohio, that's a gift. And if that family is in Pensacola, Florida, or that family is somewhere in the subcontinent of India, that also makes me feel really special. So I just want to give a shout out to people that trust me and trust my team with their care. That is a gift to us and to me. And I want to honor that gift. And so I just want to say thank you. So John Wayne writes in. Now, John Wayne is a cool name. John Wayne writes in, is there an easy way to tell if you're going into secondary progressive MS? Had MS 32 years and worried about it. So, John, determining whether you've entered a progressive phase of the disease is not straightforward. There's no blood test for it. It's really a clinical description. So if you've had relapses ever, you have a relapsing form of MS, period. So if you had one relapse, you have a relapsing form of MS. Progression can occur in the setting of a relapsing form of MS. And the best way to describe progression is worsening on the neuro exam, independent from an attack. So if you have an attack and say lose vision in an eye, and then it comes back 50%, you've accrued disability, but that's not progression. That's incomplete recovery from an attack. If you slowly over a period of several years have increasing difficulty walking and you haven't had an attack, that is the flavor of progression. And so progression, I like to define as worsening on neurological exam independent from attack. And it's never fast. People don't have they're doing okay 1 week and the next week they have progression. It doesn't function like that. In fact, progression isn't really something you can sort out unless you look back over time and you realize, hey, 2 years ago, I could do X. A year ago, I had trouble doing it. Now I can't do it anymore. And it's that slow progressive decline that really characterizes the disease. You can get a bit more granular with some of the details and definitions, but I hope that, John Wayne, this kind of helps you. The other thing that I want to say is just because you're progressing doesn't mean we're done treating you. It doesn't mean that we can't impact your disease, because we can. It doesn't mean that we should stop medicines, because we shouldn't, because they still work. Medicines in a progressive disease state can slow progression and they can decrease attacks, which people with progression can still have. People with progression can still have new spots on the MRI, and these medicines prevent that. So I would never, ever want to stop a medicine because someone entered a progressive disease state. Now, Matt Z has jumped online. What's up, Matt? How are you doing? Matt is fantastic. He's been a member of this channel for a long time. So I really love this guy. Thank you for jumping on. I'm asking the moderators to help out with identifying questions and posting them. So Matt, if you don't mind, I greatly appreciate that. AJ's HR has been doing this for a little bit now, and we're grateful. Thank you very much, AJ's HR. And the next question is from Tresha Coleman, who writes, I have pineal cysts too. What does that mean? So the pineal gland is a structure in the brain, and sometimes the gland can develop a cyst, which is like a space or like a circle, like a vesicle. And a pineal cyst does not mean something bad. So a pineal cyst can sometimes grow, and it can push on structures, particularly the structures that are surrounding the optic nerves. But you need to have that checked out. I'm sorry. I was talking about pituitary. It does not affect the optic nerves, but the pineal cyst can grow and it can push on structures. And the best way to evaluate that is with serial MRIs. Pineal cysts are normally not concerning, and they normally don't cause problems, but they can be easily followed on an MRI. And if you and your clinician identify problems, there's stuff that can be done. But I personally would just observe it and watch it on future MRIs. Now, of course, you need to talk to your clinician about your pineal cyst and what's best for you. Looking for more questions. I've got some thumbs up. I love that. There's 119 people that are online. We've been doing this for about 40 minutes. We've got 94 thumbs up. I'm hopeful that we can push that up to 100 thumbs up. So if you guys are willing to show me some love, please do so. Sebastian DeVee writes in and says, ask, do you ever feel like a plastic drifting through the wind? Wow, that's an interesting question. I can safely say, Sebastian, that I have never felt like plastic drifting through the wind. I'm also not exactly clear on what you mean. And so please feel free to write back in and help further clarify what you mean by plastic in the wind. Not exactly sure, so I'm worried I may not have answered that question adequately. All right, we've gotten caught up. Oh, look, there's 106 thumbs up online. That is rationale for opening up another can of grog. I am going to not show you which grog I'm pouring, just because I don't want to do a promotion, and I want to keep you guys guessing as far as what brand of grog we're drinking tonight. But I will describe to you that this can has a bear on it. Dare I show you this can with this bear? Ha ha ha! So maybe you guys will identify what famous bear that is and what can of grog I just poured into my grog cup. Kristen, it's not Coke. Nope, not tonight. So let's talk about a couple other questions. I will wait for here. AJ's HR has hooked it up again. So he was asking Dr. B, do you ever feel like a plastic bag floating in the wind? No, I've never felt like that. All right. So we've been on for 41 minutes. It's my goal to rock out with you guys for maybe about an hour. And then I'm probably going to have to wind down and get ready for bed. One of my big exciting things this week is this amazing hat that someone was nice enough to give me. If you guys haven't seen it, check this out. It says FUMS. I'll let you guys determine what you think that means. And in case you didn't see it earlier, if we flip it around, it says kick MS. And I can take my glasses off. Now, many of you know I am totally blind without these, so I can't really see the camera right now, which is fine because I can't see you on the other end of the camera. But it definitely fits my hat a little bit better. Now, I've got to take the cool hat off and put the nerd glasses on so that I can read the screen. I do not think that was a haiku. I've got C. Collins online. C. Collins, how are you doing? C. Collins recently started her own YouTube channel. And so if you guys haven't checked out her video, she did a really cool video, MS in the 11th percent. Definitely check her out. She's brand new on YouTube, and I'm really proud of this video that she just put out. So I've got another question from Carrie Thomas. And Carrie Thomas writes in, experiencing what seems to be symptoms of MS hug. When I sleep, I'm having trouble reading this. When I sleep, seems from side to side and it wakes me up. Does MS hug calm when you sleep? So I'll interpret this question. Someone's having the MS hug, the squeezing hug, and does it calm down when you sleep? I've heard both. I've heard people that are able to sleep. I've heard people where it keeps them awake. One of the biggest problems that I've heard about is when you lay down and you have pressure on your thorax and it kind of triggers or exacerbates the pain and discomfort. I have a video on my channel where I talk about MS hug. And so if you'd like to understand what causes MS hug or how we treat MS hug, certainly please check that video out. All right, I've got another question from Sam Woods, who writes and asks about MRI. Let's see here. Sam Woods asks about MRI contrast, saying staying in the body and causing damage. So I have a video where I talk specifically about MRI contrast, Sam. So if you haven't checked that out, then I definitely would ask you to check out that video. The short and the long of it is there's two kinds of contrast agents. There's linear contrast agents, and they're bad. So linear is bad. You don't want a linear contrast agent. And then there are macrocyclic molecules. Macrocyclic contrast in the MRI is good. So macrocyclic is good. You want macrocyclic molecules. Those are the ones that are good. And the reason they're good is they don't stick in the brain. So with linear molecules, with linear contrast agents, you can see sequestration where it sticks around in the brain. With macrocyclic molecules, it doesn't do that. And so I would simply ask the radiology technician, hey, are you using macrocyclic molecules, or are you using a contrast agent which doesn't stick around in the brain or not? And they should be able to tell you. Where I work at Ohio Health, We don't use linear molecules. All of our MRIs are done with macrocyclic molecules, and so there's genuinely no concern about it sticking around the body. So to hear a lot more about that, please check out my video on contrast. I think the title is Contrast Safe in MS MRIs or something like that. All right, what else do we have going on here? I've got another question from Number One Mom. Now that is a cool name, Number One Mom. I've got a lot of love for my mom. I'm looking forward to seeing my mom this weekend. We're going to be celebrating her 70th birthday. Isn't that awesome? My mother is turning 70 years old. She has more energy than I do. She is an amazing woman. We just celebrated the Passover at her house just last week. It was phenomenal. And I'm really excited to celebrate with my mother her 70th birthday. That's coming up this weekend. But Number One Mom writes in and says, she asks, significant spasms throughout the body. I am on gabapentin 3 times a day. Just started baclofen at bedtime. My lesions are in the cerebellum. Can you explain the significance of spasms from what area? Excellent question. So spasticity is a problem where the muscles don't talk to each other correctly. So let's say that I want to bend my finger like this. In order to bend my finger like this, these muscles have to get shorter. They have to contract. And these muscles have to relax so that they can bend. So at the same time, the flexors have to contract and the extensor muscles have to relax. And I don't tell my finger to relax the extensors, contract the flexors. I just curl my finger. In a similar fashion, if I want to bring my arm to my face, I don't say bicep contract, tricep relax. I just say beer. I just did that as an excuse to drink. But that's what's supposed to happen. And the spinal cord does that for you. When you have damage to the brain or spinal cord from MS or from something else, sometimes when you want to do this, you also want to do that. Or when you want to do this, you also want to do that because the muscles are no longer coordinating their efforts. And so you can literally get a tug of war with the bicep and the tricep, or the flexor and the extensor. And that manifests in one of 3 ways. You can have spasms, which is like a bouncing. You can have a cramp, like a Charlie horse, where you have a visible contraction of the muscle and it hurts like the dickens. Or you can have a limb that's hard to bend. Now, the question from Number One Mom was, where do those lesions occur? And they can occur anywhere in the descending pathways for the motor fibers, from the top of the brain down the spinal cord. Spasticity occurs in upwards of 70% of people with MS. It's extremely common. We have a large spasticity program where I work at Ohio Health, where we evaluate patients and we enroll them in physical therapy. We get stretching, we get splinting, we do baclofen orally, we do other medicines orally, we do Botox, we do baclofen pumps. And on this channel, I have several videos dedicated to spasticity and MS. So if you haven't checked those out yet, Number One Mom, I would totally check them out. I also want to give a shout out to Matt Z and to AJ's HR, who have been editing the content. You know, this is a place where we want to be friendly, we want to be nice, we want to play nicely in the sandbox. And so I really, really appreciate the moderators that are kind of keeping everything in line. It's super hard for me to be online talking with you and then to try to make sure that the content in the comments is appropriate and on point. And so thank you very much, AJ's HR. And thank you very much, Matt Z, for helping out tonight. I'm grateful. So let's take another question. And I've got one from, in my opinion, yes, gadolinium is much safer. Just drink lots of water. All right, so that's an excellent question and an excellent comment. And I agree with you that if you have normal kidney function, I have no concerns with you receiving contrast agent. At my hospital, we literally check kidney function with a creatinine level before we give anyone contrast. And so we know ahead of time whether or not your kidneys are okay. And if your kidneys are okay, jumping in to taking contrast, in my opinion, is not very concerning. All right, what else do we have cooking on here? Matt says you're welcome, and dude, I really appreciate you. Thank you. So there's another question from Megan, and let's see. Megan writes, I'm 10 months postpartum now. I feel like my neurologist is blaming my flare-up symptoms on my hormones. Isn't it common to relapse after pregnancy? Then Uncle Paxton here. The answer is yes, it is common. And in case you didn't see it earlier, I just posted a link, Megan, to a video that I did on pregnancy. So you can check out that link, and I talk a lot about the fluctuating hormone levels and how that can trigger an attack in postpartum. All right, so it is 50 minutes, and we're going to start to wind down. I'm going to take another couple questions, and then we're going to wrap up for the night. My channel started off as something that I would do literally in between no-shows and clinic visits. I don't know if you guys know this, but the very first videos I published on a phone in my clinic. I didn't prepare anything. I just literally decided on a topic, put the phone towards my face and talked into it, and then I published it on YouTube. And I did that when someone would no-show to my clinic. So if I had an appointment scheduled and a person didn't show up, well, then I would just do a quick video. And the majority of my initial videos were done in that fashion. And it started to dawn on me that I could use my videos to help educate and raise the level of awareness, kind of up your game and help you be the most awesome you despite having MS by creating content that would help educate you between visits. So then I started to plan my videos, and I still use my camera, but I got like a little camera stand so that it wasn't jostling about. And in some cases, I even planned out what I was going to say. Now, that was a couple years ago. I've been doing this now for, I don't know, about 2 years maybe. And over the time, it's really morphed into something which I just absolutely adore. I never in a million years thought that I would have over 250 videos on the channel. I never in a million years thought that I would have over 10,000 subscribers, and that at 11 o'clock at night or 11:30 at night, there'd be 121 people jumping online to talk to me about MS. This has become a wonderful thing for me. And I really appreciate all of your support. I really appreciate your love. I appreciate that you guys keep coming back to tune into my videos and my live streams. I love your comments. I say this all the time when I'm on making videos, but thank you for learning about MS with me. And I really mean that. I want to thank you for learning about MS with me. It's a nasty disease. It's a disease that's impacted my family. It's a disease that's impacted your family. And I want to not let MS make decisions for people. I want to arm you with education where we can educate you and empower you and energize you to fight back. And again, we'll show this hat off one more time. This is kind of how we like to feel about MS, and this is what we want to do to MS. And I want you to live the fullest life that you can despite having this disease. Let's see. I am learning how to jump on live streams, and the thing that I haven't done yet, I haven't done a good job of doing it consistently. And so, I would hope that you guys would help me out. Write in a comment and tell me what you think is the very best time to live stream. Is it best to do it Sunday nights? Is it best to do it Saturday mornings? Is it best to do it in the middle of the night on a Thursday? Tell me what you think in the comments below. As always, I appreciate you. I appreciate your questions and comments. And if I didn't get to them tonight, I'm going to. I love to read through the post where I can then go back and identify awesome questions, and I make some videos and I talk about those. And if there's a video topic that you would like to hear about, as long as it's about MS, I can't do cars or love or sports or politics, but I can do MS. Let me know what those topics are. So with that, I'm going to sign off tonight. Thank you all very much. I love you guys. I love this global village. You mean the world to me. So until my next time online, whether that be a live stream or one of my new videos, I want to say thank you for learning about MS with me, and take care. Have a great night, guys.